Hey everyone, it's Nurse Dani, and I'm here today with Dr. Dizon-Townson, and we go way back. We worked together for over a decade while I was on labor and delivery, and then closely for a couple of years while I was in MFM. She's fantastic. So I want to give you a second to tell everyone a little more about you, but after the introduction, just so everyone knows, the topic of our live stream today is gestational diabetes, so stay tuned. Dr. Dizon-Townson is an expert on that and many things pregnancy, so tell us a little bit more about yourself.
So I'm a maternal fetal medicine physician. I've been working at Utah Valley Hospital for about 20 years. I was born in Ohio. I did most of my training in Texas and then have been out in Utah for about 30 years. My husband is also an OB-GYN. I'm proud mother of 2 young men.
That's quite the team. 2 OB-GYNs in one family. That's awesome. You guys are great. So gestational diabetes, this is a passion of yours, and you have done a lot, especially in Utah County, for women who have gestational diabetes. Let's start out by talking about what is it exactly?
So gestational diabetes is glucose intolerance that's really first picked up during pregnancy. It's fairly common, and it does have really some important risk factors that patients should be aware about during pregnancy.
Like what? What effects can it have on a mother and her baby?
So there's several effects. One of the biggest concerns is that poorly controlled gestational diabetes can be associated with bigger babies. Bigger babies are associated with birth trauma and a higher risk for cesarean section. That's one of the main risks with gestational diabetes. A second risk is excessive amniotic fluid. Excessive amniotic fluid can be associated with preterm labor, preterm delivery. The third risk is preeclampsia. Preeclampsia is high blood pressure during the pregnancy, protein in the urine, and rapid weight gain from swelling. And one of the most important risk factors for gestational diabetes is the risk that the mom can develop adult onset diabetes after the pregnancy. So those are really important risk factors that patients who are diagnosed with gestational diabetes during pregnancy should be aware. If gestational diabetes is well controlled and patients have good follow-up with their physicians, then the risks can be minimized. So good follow-up is really important for this pregnancy condition.
So what exactly is the difference between gestational diabetes, type 1 and type 2, out there for everyone who's listening who might be wondering? What is the difference?
So gestational diabetes is glucose intolerance that's first diagnosed during pregnancy.
So you haven't had any issues with blood sugar control prior to pregnancy. It develops during pregnancy. And why are you able to develop that during pregnancy?
Well, there are certain risk factors that contribute to an individual's risk for gestational diabetes. One is obesity. Obesity, there is a higher risk of developing gestational diabetes. Different ethnic populations have a higher risk of developing gestational diabetes. Hispanic moms have a higher risk. Asian, Pacific Islanders, and Native Americans have a higher risk for developing gestational diabetes during pregnancy. Also, as moms get older, there's a higher risk of developing gestational diabetes.
So it's not one of those things where if you didn't have it on your first, you're not going to have it on your others.
Correct, correct,
but
definitely.
It gets more likely as you have more children.
Exactly.
So during pregnancy, is there a possibility for gestational diabetes because you need more sugar in your blood to feed the baby, but sometimes your body overcompensates? Is that kind of at a microscopic level how you might develop it and things go wrong?
So when you talk about gestational diabetes or diabetes in general, it's very important. There's different types of diabetes, as you said initially. There's type 1 diabetes where patients are insulin deficient. They don't make enough insulin to maintain normal blood glucose levels prior to pregnancy or during pregnancy. And then there's type 2 diabetes where not only you can be somewhat insulin deficient, but even more importantly, you can be insulin resistant. So it's important to understand what insulin does. Insulin's a hormone. Insulin helps individuals utilize blood glucose and helps the transport of blood glucose from the blood into the patient's cells. And people who have type 2 diabetes or gestational diabetes, insulin is not working in getting the glucose to where it needs to be. And so individuals are insulin resistant. what happens during pregnancy, you have a lot of hormones that are acting on an individual's glucose metabolism. Early on in pregnancy, you have higher levels of estrogens and lower levels of progesterones. Later on during pregnancy, that ratio switches, and that can cause individuals to become more insulin resistant. And so that's typically why individuals may not be picked up with gestational diabetes early on in pregnancy, but then they're picked up later on in pregnancy.
So when do you typically screen then?
So an individual without risk factors, typically we recommend screening with a 1-hour oral glucose tolerance test at 24 to 28 weeks gestation.
That's a nasty drink.
Yes,
right?
Unfortunately, it is very nasty.
Yeah. So 24 to 28 weeks. So what happens if I take the test and I find out that my blood sugar was like 142? So what are normal ranges and what warrants further testing?
So most labs will use an abnormal value as 140 or greater on the 1-hour oral glucose tolerance test. Some labs use a value of 130 or higher for an abnormal 1-hour glucose tolerance test. If you switch that from 140 to 130, your sensitivity of the test, or the ability of the test to be able to pick up an abnormality, increases, but then also your false positive rate increases. Right. So with either an abnormal 1 hour of 140 or an abnormal 1 hour of 130, depending on what that physician's lab uses, then it's important to do a 3-hour glucose tolerance test. Unfortunately, the 3-hour glucose tolerance test is double the glucose load. So instead of a 50-gram screen, you're using a 100-gram screen. Individuals who have to undergo the 3-hour test have to be fasting for at least 12 hours, and they have to drink the 1 hour, the 100-gram screen for the 3-hour test.
And that just involves testing your blood at 1-hour increments after to see how your body's tolerating all that sugar, correct?
Correct. So you'll check a fasting. So before you even take the 100-gram screen, you'll get a fasting blood glucose level. And then 1 hour after the test, you'll get another blood draw, and then 2 hours and 3 hours. 2 out of those 4 values, if they're abnormal, then that gives the patient a diagnosis for gestational diabetes, and then they should be referred for very intensive glucose monitoring and dietary therapy.
Okay, so then they might come see you in maternal fetal medicine, and then how are they plugged in the system, and what kind of management can a patient expect, especially if they come to Utah Valley, because you've done so much to streamline it and kind of make it like a one-stop shop?
So I'm really fortunate to work with some very good diabetic nurse educators and dietitians, and we have a really nice setup for patients. We've tried to really foster and nurture a one-stop shopping for patients. We know patients are very busy. They have a lot of other obligations in their life. So what we've really tried to do is foster one-stop shopping for the patient, where they come to our office, they have an ultrasound, they have a consultation with one of the maternal fetal medicine physicians. After the consultation, they'll meet with a diabetic nurse educator. The diabetic nurse educator then does a very thorough job in documenting what their blood glucose levels have been over the past 1 to 2 weeks. And then we review those blood glucose levels with the diabetic nurse educator. And if we see 50% or more of those blood glucose levels exceeding target values, then we'll sit down and have a discussion regarding the initiation of medical therapy.
So what are target values? What is a good blood sugar level for a woman who has gestational diabetes? What are you shooting for?
So our target values for, in regards to encouraging optimal glucose control during pregnancy.
To minimize all those side effects from all
right,
babies
exactly.
that we talked about. Exactly.
So good blood glucose control during pregnancy will minimize the risks of an excessive fetal growth, excessive amniotic fluid, preeclampsia, and then the risk of adult onset diabetes. And those
control during pregnancy will actually affect your chances of getting type 2 diabetes?
Certainly.
Okay.
Certainly. Good tight glucose control can really minimize those risks. So optimal target blood glucose levels that we always discuss with patients are fasting sugars between 75 and 95, and then either 1 hour after meals, also called postprandial sugars, of 140 or less, or 2-hour postprandial sugars of 120 or less. We try and patients, depending on what their schedule is, they can either check 1 hour or 2 hours after meals. The important thing is that they're documenting what their sugars are, they're recording them on a piece of paper, and then they're in continual communication with the diabetes nurse educator during pregnancy. The important thing is that patients and everyone need to realize is that as the baby gets bigger, as the gestation progresses, as the placenta gets bigger, the placenta makes a lot of hormones that act against insulin. So pregnant women can become increasing insulin resistant during pregnancy. So where they may have done really well during pregnancy at 28 to 32 weeks gestation, they may notice that their blood glucose levels are progressively increasing at 32 to 34 weeks gestation.
This is why you watch so closely, because it can change within a week or two.
Exactly.
And you might need different management options. Like if you start out with diet or exercise, then you might all of a sudden need oral medication or insulin.
Exactly.
So you have to keep your appointments.
Right.
And track those blood sugars.
Right. Exactly.
Okay. So diet, there's a lot to that too, because like all my friends that have had gestational diabetes say it overtakes their life, and it's a pain because all they feel like they're ever doing is eating and taking their blood sugar.
Yes.
And that is kind of how it is, but it's so important to do, because without those things, then you have these complications. So what is the importance of diet in all of this?
So diet's really important because glucose metabolism during pregnancy is somewhat different than when you're not pregnant. And it's very important that your sugar levels are under much more tighter control during pregnancy than in the non-pregnant state, especially when you have a diagnosis of gestational diabetes. What happens during pregnancy is that when a mother has high glucose levels, those glucose levels then are transported from mother through the placenta to the baby. And then what happens is the baby sees very high levels of glucose. And what the baby does, or the fetus does in response to that, it starts making more insulin. Insulin causes babies to grow. Insulin acts like a growth factor during the pregnancy. And so that's what causes babies to be bigger during pregnancy. The other issue is when the baby sees higher levels of glucose, it makes more fetal urine. And more fetal urine can lead to excessive amniotic fluid or hydramnios. So really good, meticulous blood glucose control during pregnancy can minimize those risks.
As well as after delivery.
Exactly.
Because if a baby's making a ton of insulin to deal with all of this blood sugar, but then their supply is cut off at birth, their blood sugar plummets.
Exactly. So babies of mothers that have poorly controlled gestational diabetes are at higher risk of having low blood glucose levels or hypoglycemia after delivery. The other important thing to note is that pregnant women who have gestational diabetes, the majority of them can be managed on diet only. Many women do not have to go on medications during pregnancy, but it's hard to know that without doing meticulous blood glucose monitoring during pregnancy. So that's why we recommend very close follow-up with your physician, with the diabetes nurse educators during pregnancy.
And then at a certain point, it's standard to start non-stress tests, correct? And what's the importance of that? What role does that play?
So that's a really good point. So if mother is what we call an A1 gestational diabetic, that they have they're meeting good optimal target blood glucose levels just on diet only and not requiring medical therapy, we know that those pregnancies, the majority of those do absolutely fine and don't have complications. So we actually we don't recommend a lot of testing or a lot of antenatal surveillance for those pregnancies. It's the patients who have other comorbidities or who do not have optimal target blood glucose levels with gestational diabetes, or who are on medications, either an oral medication like metformin or glyburide or insulin therapy. If those patients require medical therapy, then their risks of adverse pregnancy outcome are increased, and we do recommend closer follow-up, including antenatal surveillance with non-stress tests, weekly amniotic fluid checks, and then ultrasounds to assess fetal growth.
What does a non-stress test tell you about the well-being of a baby?
So a non-stress test is a good way to assess fetal well-being. Is the baby happy and healthy on the inside? Is the fetal heart rate tracing normal? And how the baby is doing on the inside in response to various glucose levels or in response to different medications.
Well, that's a helpful test. It's not our best test, but it's the best thing we've got, even though it's not perfect. Is
Exactly.
What I'm trying to say. Yeah.
And I always encourage patients, a very good, not expensive test is just maternal assessment of fetal movement or doing kick counts at home. And I try and tell patients when I tell them and give them guidelines to assess fetal movement, I prepare them. Babies tend to sleep a lot in the womb. They sleep anywhere between 20 to 24 hours. They sleep a lot, around 20 hours a day in the womb. But the best time to assess fetal movement is after they've eaten. After they've eaten, babies see an increased glucose level, and that's when they tend to be most active. So I always encourage patients, check fetal movement after you've eaten. Baby should move at least 10 times in a 2-hour period after you've eaten. If baby doesn't move 10 times in 2 hours, come on into labor and delivery for assessment. If baby moves 10 times in the first 15 minutes, you don't need to keep counting for the full 2 hours. So that's how I try and encourage patients to assess fetal well-being when they're at home.
One of the OBs that I'm sure you worked with a long time ago has a wife who's told a story before that when she was pregnant, she got into bed and, he was actually home that night. He wasn't off delivering babies. And she was just kind of laying against him. The baby was super active and of course, keeping her up. And he's like, scoot over. The baby's keeping me up.
They do.
All people, an OB would say that. But some people feel like it's uncomfortable when the baby moves, but it's a reassuring thing to look for because that means they're doing well.
Exactly. And anything counts as a fetal movement. A kick, a punch, a roll, a hiccup, all that is included.
Hiccups are good. I think that's important to highlight because a lot of people worry that their baby's having seizures or something in the womb. Mm-hmm. But it's normal if you feel little rhythmic movements.
Yeah.
That's actually a sign of well-being.
Yes.
Okay, so we've talked about during the pregnancy. Afterwards, if you have a greater chance of developing diabetes as an adult, what's testing like after to see if you're getting that or developing that?
So it's very standard. And what we've seen in the past is that, unfortunately, we haven't had great follow-up with patients in doing their postpartum screening. But I really emphasize, and it's become a part of my consultation with patients, to really emphasize the importance that they undergo a postpartum glucose screening test.
Press upon them to request it.
Exactly.
In case no one else prompts it.
Exactly. And we've done a lot of education with physicians in regards to the importance of glucose screening postpartum. And I always tell patients it's an important issue not only for your health, because you want to know if you have prediabetes or adult onset diabetes. It's very important for the health of a future pregnancy. You want to know what your glucose level is early on during the periconception time period because that's when it has an important impact. So standard of care now is to recommend screening between 6 to 12 weeks postpartum. And I always tell patients you should either have a fasting blood glucose level or a 2-hour 75-gram oral glucose tolerance test or a hemoglobin A1C. One of those tests should be done at approximately 6 to 12 weeks
and you go
after
back and
delivery.
See your doctor about that time anyway.
Exactly. And if it's normal, which hopefully it is normal, we want to make sure that patients are screened every 3 years because, again, if you look at long-term studies of patients who have a diagnosis of gestational diabetes, about 50% of those individuals will go on to develop adult onset diabetes.
That's pretty significant.
So
what
really,
can you do anything to reduce that risk?
Certainly, dietary measures, exercise, really living a healthy lifestyle, which I know is always a challenge when you have a newborn at home. You really want to try and focus in as healthy as possible lifestyle, and then getting good follow-up and making sure, even if it's normal postpartum, that you undergo screening every 3 years.
I think we talked about age being a factor,
exactly.
weight being a factor. As time goes on, those things get harder to control.
Yes.
Okay, so anything else that you feel would be helpful to women out there in regards to gestational diabetes?
Well, I just want to encourage that, again, most people with gestational diabetes do absolutely fine during pregnancy. And most women with gestational diabetes don't require medical therapy during pregnancy. But if continual assessment of the blood glucose levels are not meeting those target values, it's so important for their health, for the pregnancy's health, for their fetus's health, to really to have close follow-up and medical therapy if indicated. And we do recommend in this day and age that insulin is the best medication with the best, tightest control during pregnancy if it's medically indicated based on their blood glucose levels. The other thing that's really become standard of care with recent evidence and recent data is that there are a certain subgroup of women that really should be screened very early on in pregnancy who have for gestational diabetes. For example, if they have a history of gestational diabetes, standard now is have a 1-hour glucose tolerance test very early on during the first trimester when they first present for prenatal care. If that 1-hour screen is normal, then again, rescreening it again at 24 to 28 weeks gestation.
To see if it developed.
Exactly. Because of those hormonal changes that occur during a normal pregnancy. They can affect your glucose intolerance, and you may be normal early on in pregnancy, but then later on when all these hormones are being produced by the placenta, you can be abnormal later on in pregnancy. So if you've had a history of gestational diabetes, or if you're obese, or if you're older, all those things deserve early on glucose screening early on during pregnancy and not waiting till the 24 to 28 weeks gestation.
You might need to start therapy earlier then.
Exactly.
And do whatever you can to reduce the risk.
Exactly.
So it sounds like actually a pretty positive message because a lot of this is within your control. If you monitor it, if you do what you can to be as healthy as possible going into a pregnancy, being at a healthy weight, knowing your health history, addressing problems before you conceive, making and keeping all of your appointments, monitoring your blood sugars, monitoring for fetal movement, then you can have a good outcome.
Yes, I think that's a very good summary.
Okay. Well, thank you so much for your time. I know it's valuable.
Thanks for having me.
She really is awesome. If you guys have a chance to meet her, I mean, working in maternal fetal medicine, I always said, I don't want to see my friends here, but if I do have to see you here, then you know that you'll be well taken care of.
Thanks.
So thank you so much, Dr. Dizon-Townson. Thank you for joining in. And of course, you guys know if you have questions, you can find me on Facebook or Instagram. Thanks so much and have a great day.